Hello, everybody. I know people are just filtering in after lunch. So I know that like all the alkaline tide or something after eating, it's just you might feel a little sleepy. Hopefully, we keep it interesting enough that you'll pay attention. And I'm up here with Molly Turco. Molly Turco is our senior advisor in the Center for Medicare, focused on Medicare Advantage, and has many years of experience in Medicare Advantage as well. So we're going to have a little bit of a conversation later. My name is Doug Jacobs. I'm the Chief Transformation Officer in the Center for Medicare, internal medicine by training, and I help to lead some of the health equity efforts at the Center for Medicare. And so today I'm going to walk through some of what we're doing within the Center for Medicare, and then we'll get to that discussion with Molly and talk about Medicare Advantage, and then we'll open it up for questions and discussion. So strap in. We'll get started. So just some background on Medicare. Medicare covers more than 63 million Americans, and we partner with more than 1 million clinicians and 6,000 hospitals. About half of people with Medicare have Medicare Advantage. You might have been reading about the fact that Medicare Advantage enrollment is growing. And Medicare really has this background that is one that includes civil rights. And so Medicare itself has historically played this catalyzing role. When there was still segregation, Medicare was one of the first entities to require desegregation as conditions of participation in the program. And it required hospitals, nursing homes, home health agencies, hospitals to desegregate, and played an important role there. So with that storied history, we have our work cut out for us collectively now, and looking at the profound inequities that exist in society today, and how we can think about leveraging Medicare. So us, like the rest of the centers at CMS, are working under this framework to address health equity. And we have really 5 core areas that I'm going to walk through now, and that I'm going to dive deeper into and tell you about what Medicare is doing in these areas. So to start out, the first priority is data collection and analysis of that data. And that's really important to build this evidence base of how we can think about moving forward and addressing some of the inequities that exist. Number 2 is addressing the causes of disparities through policies and through operational changes. Number 3, building the capacity of healthcare providers to address those inequities. Number 4, addressing language access and culturally and linguistically appropriate services, oftentimes abbreviated CLAS. And priority 5, improving all forms of accessibility for healthcare coverage and access. So with that in mind, we'll dive deeper first into the first topic. Just to say also that we published a piece on our health equity efforts in the Journal for the American Medical Association, JAMA, talking about how we were thinking about leveraging Medicare to advance health equity. And so that's a resource for you as well. If you don't remember anything I say during this talk, or don't want to look at the slides, that's another area where you can turn to, because a decent amount of what I'm going to be saying today is in that publication as well. Okay, so priority number 1, the collection, reporting, and analysis of standardized data. We've taken important steps here. Number 1, we have now, as part of Medicare Advantage, these optional questions at enrollment to collect self-reported race and ethnicity data. I think, as folks know, self-reported race and ethnicity data is more the gold standard. We also use an imputed system to otherwise get race and ethnicity information to do better analyses within the Medicare program. There we go. We've also been thinking about health equity analysis when we come out with our rules. So we pay for a lot in Medicare. We come out with, it's hard to count the number of rules, but it's like 15 rules, maybe on any given year in various payment systems. And so in each one of those rules, we have an analysis of the impacts of the rule. And so what we've started doing is, starting with hospitals, looking at the impact of the changes in policy on the hospitals, and looking at specifically those safety net hospitals as well. So this is just I don't know if you all can see this or if it's too small, but you can just take my word for it that it's a kind of a table that's stratified by different characteristics of the hospitals, looking at the effective changes in the inpatient prospective payment system, or IPPS, which is our hospital-based rule. So, okay, so that was priority number one. And priority number two, and I feel like this could be the topic of the really probably the entire talk because there's so much in here, but addressing inequities in policies and operations to close gaps. So I tried to limit myself to 3 points that I wanted to make here. And the first is related to the social determinants of health. And so we're going to dive more into that. The second is about this concept of rewarding excellent care delivered to underserved populations, which is how we're thinking about combining quality, payment, and equity. And then third is some of just operationally, how are we thinking about this? Because Medicare is a large program, and a lot of what we do is running a payment system, and it falls under this operations bucket. So I'll talk more about that as well. Okay, so social determinants of health to start. I think so. Most recently, I came from Pennsylvania, and Pennsylvania, like every state throughout this country, has tremendous inequities. And so this is a map of Philadelphia. And the areas in red on this map are areas of very low life expectancy. The areas in blue are areas of high life expectancy. And the differences here are just incredibly profound. If you're born in certain census tracts in northern Philadelphia, your life expectancy might be as low as 64. I'm not even getting to Medicare eligibility if you're not disabled or have end-stage renal disease. And if you're born just a mile to the south, your life expectancy goes up to about 87. That's a difference of more than 20 life years. And just to put that into perspective, I mentioned I was an internal medicine physician. I see primary care patients. A lot of patients have cardiovascular issues. If we were to eliminate cardiovascular disease, that's a life expectancy difference of about 4 years. So a life expectancy difference of more than 20 years, just based on the block that you're born, is an incredibly profound inequity. And this is not just only Philadelphia. If we were to look at other maps of Philadelphia, though, and we looked at physical health outcomes, so heart disease and stroke, the map would look the same. If we look at behavioral health outcomes, cases of substance use disorder and depression, the map looks the same. And if we were to also look at a historically redlined map of Philadelphia from the 1930s and 40s, the map would also look the same. So these are inequities that have existed for generations. And I think part of us coming here today, which is extremely exciting to talk about some of these health inequities and what we can do about it, it's really going to take more than just one agency and more than one provider, more than one plan, more than one patient to address these profound levels of disparities. And so bridging this into the social determinants of health, a lot of this, when you look in the areas that have lower life expectancy, there's less access to food, there's less access to stable, well-paying jobs, there's less access to educational institutions that are high quality, there's less access to skilled nursing facilities that are high quality. And so there's a great impact of the social determinants of health, and we're increasingly thinking about how we can start to bridge the healthcare, what has traditionally been the healthcare system, and the social care system that has existed for many years as well. Okay, so the social determinants of health, I think I'm not going to explain what the social determinants of health are to you. Hopefully by now, I think folks are aware of it. And so what have we been thinking about in Medicare? This really starts with screening, but doesn't end with screening. So screening, we now require special needs plans, which are a special type of Medicare Advantage plan, to ask questions related to food, housing, and transportation as part of the health risk assessment. And we've also have new quality measures at a hospital level that we put first in the hospital inpatient quality reporting system that look at the percentage of individuals who are screened for these social determinants of health issues. And I mentioned that's not where we want to end up, though. The idea is not just to screen more individuals. We need to think about this more as a care continuum, and what happens with those individuals after they're screened. Where are they referred to? Are there partnerships that are developed with community-based organizations? And are those community-based organizations supported to address additional people who are being referred to them? We have started to advance some policies to help address this. We have incorporated now what we're calling advanced investment payments in the Medicare Shared Savings Program. Just as some quick background here, the Medicare Shared Savings Program is the largest ACO program in the country. It serves, there's almost 11 million people with Medicare that are assigned to an accountable care organization in the Shared Savings Program. And what we're trying to do here, what we've seen over time, is that there's actually not enough ACOs, accountable care organizations, in underserved areas. And so with these advanced investment payments, which we're saying, if you're a newly forming ACO, smaller ACO, we're going to give you these advanced investment payments that you can use to address social needs of the people that you serve. Also to invest in infrastructure and hire new staff. And so this is one of the first times that we've said with traditional Medicare payments that they can be used for these purposes. And we're also, and this is actually starting January 1st, 2024. So we finalized this policy last year in the physician fee schedule, and now it's we're working on implementation before it goes into effect. Okay. Also, this has been the case, and this is ongoing, is that Medicare Advantage organizations can leverage special supplemental benefits for the chronically ill to address the social needs of individuals with Medicare Advantage specifically. And then the other area that I wanted to highlight here is we're increasingly, in some instances, identifying situations where individuals with unmet social determinative health needs may incur additional cost. I'm not saying this is going to be the case across the board or in every situation, but where we have seen this is the case is in hospitals. We've seen, when we looked at our data within Medicare, we've seen that patients who are homeless, the hospital actually uses a lot more resources to take care of that person. And so what we proposed in the recent inpatient prospective payment system rule, IPPS for hospitals, was that homelessness is going to be, we were proposing that it was going to be a comorbidity or complication. And what that means is, in the MSDRG system, if you are familiar with it, that hospitals, when they're discharging patients who are homeless, would be paid more if the patient that they were taking care of for that admission is homeless. And so that is in proposed rule form, so that is not yet final, but I wanted to highlight that in case folks haven't seen it. Okay, so we could probably spend the whole time on social determinants of health, but we're not going to. Oh, one more piece. I couldn't resist. One more thing is we came out with a, actually, let me take a step back. When we're thinking about this idea of a continuum of care to address social determinants of health, there are healthcare systems that haven't historically addressed social needs. There's FQHCs and outpatient providers, and then also the community-based organizations who have historically addressed these social needs haven't historically worked together with the healthcare systems and vice versa. And it can be a completely different language that's spoken in the social services worlds compared to the healthcare policy worlds. And so one thing that I wanted to highlight for you all is there was a piece that came out where there was many different authors across HHS with this idea of improving these connections through this idea of a community care hub. And the idea of a community care hub is you can have like a larger community-based organization that acts as the go-between between a lot of the different healthcare systems and the smaller community-based organizations as well. So in case that is an unfamiliar concept to you and you want to learn more, I put this here for your edification as well. Okay, so the second piece that I wanted to highlight today under this priority number 2 is this idea of rewarding excellent care for underserved populations. And this is how we're thinking about combining our quality and value programs and payment and equity. And so first I'll tell you what it's not. And it's not, what we're not doing, we're trying to avoid some of the pitfalls, is we're not risk adjusting away disparities and thereby masking them. You might imagine that because the outcomes that exist for underserved populations are worse, some people have said over time, let's just risk adjust away the disparities to equalize payment. That's not what we're doing here. We're also not setting lower standards to treat underserved populations. And I think that that's really important as well, because everybody deserves the highest quality care. What we are doing, and I'll break this down, is rewarding excellent care delivered to underserved populations. So breaking that down like piece by piece, by reward, we mean an upside only payment. So an upside only reward. By excellent care, what we mean by that is like high quality care, at least average or above. And then for underserved populations, we're defining it in different ways in different programs. We're really trying to focus on those providers who are serving underserved populations. So what this means is if you're a provider or plan serving underserved populations, you could be eligible under what I'm going to talk about in these different payment systems for an upside only reward if you provide high quality care to patients who are underserved. So the reason why we think this is important also is that it creates more incentives to treat underserved populations too. Because if there's an upside only reward that you would become eligible for, there's more incentive to improve access to underserved communities too. And we know that underserved communities have historically underutilized the healthcare system for a variety of different reasons. So where is this? I'm kind of talking about it in concept, but we've actually finalized 2 policies and proposed 2 others that builds on this philosophical framework. So the first is what we've termed the health equity adjustment in the Medicare Shared Savings Program. That's that same ACO program that I was talking about earlier. We've also finalized this. We called it the Health Equity Index in Medicare Advantage, and that's in this STAR ratings program for Part C, Medicare Advantage, and Parts D. Also, we've proposed it in the hospital value-based purchasing program. We proposed that in the inpatient prospective payment system rule. That's the hospital-based rule. And then we proposed it also in the skilled nursing facility value-based purchasing program as well. So just to kind of draw this thread across different programs in Medicare where we've had a similar philosophical approach to combine this idea of quality and payment and equity to reward excellent care delivered to underserved populations. Okay. Let's see, there we go. Okay. So the next thing I wanted to highlight in particular was some of what we're doing with operations, like how we run Medicare. We're really trying to think about very holistically to make sure that we're doing so in such a way that that promotes equity. And so the first we have as one of our pillars, just engaging interested parties in various ways, shapes, and forms. We're really trying to be deliberate about engaging interested parties that have historically come from underserved backgrounds that are not necessarily the folks with like the biggest lobbying like check in their pocketbook or something like that, but are really serving underserved communities in particular. And we're trying to be diligent and thoughtful about that. And we're also looking at our programs that exist today, and without making any policy changes, saying how do we make this program work better for underserved communities, just in terms of our outreach and engagement also. So we have the Medicare savings programs that can help people with their help people afford their Medicare. And so we've seen an uptick in people that are signing up for this program as well as a result of our combined efforts across CMS. Okay, so this is priority number 3, building the capacity of healthcare organizations and the workforce. Hopefully everyone's still following along. The post-lunch stupor hasn't set in completely. Okay, good. So let's see if I can go. There we go. So one of the things that we've started implementing, we're implementing one of the largest increases into Medicare graduate medical education funds in over 20 years. And so we got more than 1,000 slots that we're prioritizing for rural and other underserved areas. And we're using specifically the health professional shortage areas to identify those programs. And we released the first 200 slots this last year. And the majority of them actually went to primary care providers. So we thought that was an exciting outcome as well. Number 2, CMS has also made significant changes to telehealth during the pandemic. And I'm sure that you all have probably heard a lot about telehealth during the pandemic. We are trying to think about telehealth in equity mindset as well. And what we've seen, and actually I deliver telehealth services, that not everybody has access to audiovisual technology, and a lot of folks only have access to audio only technology. And so when we were said by Congress that we could expand telehealth, telebehavioral health services permanently, we also did so not only with audiovisual, but also audio only technologies. And we think that'll be just super important to expand access to behavioral health, and especially in rural areas where we know it can be harder to access telehealth. Telehealth can be an important way to access care. Okay, and third, we have, in addition to these metrics related to the social determinants of health for hospitals, there's also a commitment to health equity measure that's been put into the hospital inpatient quality reporting system. And it's a process measure looking at different aspects of the hospital that are important to promoting equity. So for example, is the hospital looking at its data in a stratified way? Are they stratifying their data? Are they also looking at an annual health equity plan? And that includes the senior leadership of the hospital. So I wanted to highlight that as well. Okay, the next priority, advancing language access and health literacy. My clicker is a little slow. There we go. So we've done a lot of work, particularly in Medicare Advantage in this space. We've required multi-language inserts in all required Medicare Advantage plans that direct people to further free language and translation services. We've also had new requirements. When we think about health literacy, I just was talking about telehealth. Digital health literacy is also becoming increasingly important. So we have new requirements for Medicare Advantage organizations to offer digital health education for individuals that have been shown to have low digital health literacy. And we've said that Medicare Advantage organizations have to ask people about and have some screening questions related to digital health literacy. Trying to get to my third one. There we go. And we also have new requirements for Medicare Advantage plans when they create provider directories to put a provider's language in that provider directory, including American Sign Language too. I think so often when people are looking for care and they're looking in these provider directories, seeing a provider that speaks your language can be really important for folks. So we're excited about these changes moving forward. And the last priority number 5 is, but certainly not least, is increasing all forms of accessibility to healthcare services and coverage. And I tried to limit myself to 3 points on this one as well, and I'll go into greater detail. Access to medically necessary services, access to behavioral health services in particular, and we've started talking about that a little bit already with the telehealth, and then access for individuals with disabilities. So starting with access to medically necessary services to start. The first is screening. There's so many different categories we could look at that have inequities. Cancer screening is one of those categories. And in particular, colonoscopies, there's these very well-known inequities that exist. And so we looked at, within Medicare, what we could think about doing. Many people get a stool-based test before they get a colonoscopy. So it's a take-home test that they can use to see if they need to get a colonoscopy. And when that stool-based test is positive, then they need a colonoscopy. And historically, Medicare said, okay, well, that colonoscopy is a diagnostic colonoscopy. And what that actually means is because it's a diagnostic and not preventative colonoscopy, there's actually a coinsurance attached to it. And that was very limiting for a lot of people. And so what we did is we redefined that follow-up colonoscopy as part of the prevention so that there's no cost sharing attached to it. And so we think that that's going to, and that in addition to lowering the screening age from 50 to 45 in line with the USPSTF. And also one of the really big things we've done recently is we finalized important policies related to prior authorization in Medicare Advantage. And we'd heard from a number of different stakeholders that some of the prior authorization policies were making it difficult to access care. And so we finalized policies that state in Medicare Advantage, the prior authorization coverage criteria can be no more restrictive than in traditional Medicare. And we think that this is going to actually have very important equity implications. When you think about what it takes to, if you get a denial in your care, the amount of resources it takes to actually figure out how to appeal that and go forward with it. And so by saying that it can be no more restrictive than traditional Medicare, we really think it's going to help improve access, in particular for underserved populations as well. And the last area I wanted to highlight here is we're paying for dental services that are integral to covered other medical services. And so we finalized some policies. First, identifying a process by which CMS collects information about these dental services that are integral to other medical services. And then also we finalized some policies about those situations where we're going to pay for dental treatment as well. And so I wanted to highlight that too. Okay, access to behavioral health. Like any one of these slides could be like a whole thing. So I'm trying to contain myself. Molly's giggling. Yeah. The first is mobilizing the behavioral health workforce. We've created a number of policies that have trying to make it easier to access behavioral health services. So in addition to the telehealth extension permanently that I talked about earlier, we've also said that supervision requirements that they can happen under general rather than direct supervision. That sounds very wonky, but what does that actually mean in practice? Well, I'm a primary care physician. When I supervise someone, I can either be on site looking at them physically, or I can be like generally supervising them, which means I don't need to be physically on site. And for the longest time, behavioral health services, I had to be physically on site to supervise those services. And so we made the change that for all behavioral health services, the supervision can actually be general rather than direct. And so that means that if I don't work on a Friday or something, I say take a long weekend, then those behavioral health practitioners can still practice. And I can supervise. I don't have to be physically on site for the supervising. Also, okay, making care more effective. We've also created new payments for team-based care for chronic pain. And we also mentioned the telehealth for behavioral health. And substance use disorder in particular has become especially something that needs to become especially acute. And what we've done is we finalized payments for mobile treatment that can be offered through vans. This kind of substance use disorder treatment can be particularly effective at reaching rural populations, but also other hard to reach populations like homeless patients. And so we finalized some changes that allowed substance use disorder services to be delivered in that way. And also we increased some of the payment rates for opioid treatment programs. And we also said the initiation of buprenorphine can happen over telehealth too. So, and for individuals with disabilities in particular, I wanted to highlight a few areas. The Health Equity Index that we talked about for Medicare Advantage specifically looks at care for individuals with disabilities. Also, we had a proposed national coverage determination that would, for the first time, expand coverage for power seat elevation equipment for wheelchairs. And so that's been, I think it's been an important way of promoting equity for individuals with disabilities as well. And then lastly, requiring Medicare Advantage organizations to provide that language, including ASL, can be especially important for individuals who communicate through ASL. So just to wrap up this the slide portion of this presentation, we have this definition of health equity, that the attainment of the highest level of health for all people, where every person has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, and other factors that affect access to care and health outcomes. And that goal is not just an internal goal for CMS, but I think it's a call to action for all of us. And how we can think about addressing these really profound levels of inequities. I started the presentation with that more than 20 life year difference based on the block that you're born in Philadelphia that exists in cities and towns and rural communities throughout our country. And so I think going forward, this is not only about what we have done and put it into place through policies, but want to hear your ideas and your thoughts and what's working in your communities, what's not working in your communities, and continue to engage on this going forward. It's just really exciting to, I think, be here all together today in a health equity conference. And so Looking forward to the discussion. So with that, now, yeah, I'm going to switch roles now. I'm discussing. I'm the moderator now. All right. Is this on? Can you hear me? Okay. So, thanks for joining us.
Of course.
You want to?
Yeah, that'd be great. So as Doug said at the top, I'm Molly Turco. I work with Doug at the Center for Medicare at CMS. We both work in the front office of Dr. Mina Shamani, who is the head of Medicare. So we work closely together on all issues. Doug day job, as I say, focuses a lot on traditional Medicare, and my day job focuses on Medicare Advantage. But on issues related to health equity and value and other topics, Doug is our leader across programs. So it's really a pleasure to be here together because we can really talk to our efforts across all of Medicare.
The feeling is mutual. Thanks for being here. So we talked about a lot of policies in Medicare Advantage. And are there certain policies in particular that you think will be most effective or make the biggest difference?
Yeah, it's a great question. I think, as you saw Doug go through, we're doing a lot. We're doing a lot in all aspects of Medicare Advantage. I think, I think they're all complementary to each other. I think as Doug displayed, I was thinking about as you were talking that it's really embedded in everything we do. And our leadership says that we have these briefing memos when we are briefing to Dr. Seshmani or Administrator Brooks LaSure or Secretary Becerra of the policies we're thinking about. And one section is, summarize the policy. How much will it cost the government? And there's a health equity section. So it is really about one of the key topics that no matter what we're briefing on, we have to think through that issue through the lens of health equity. And I think that just demonstrates that everything we're doing, even if it's not in the technical bucket of what Doug went through, that we're thinking about, we have this really amazing set of levers at Medicare and across CMS and HHS generally. And we're really challenged by leadership to think about that everything. So, I definitely think they're all complementary. I will say that in terms of specific things that I am excited about, I think you already pointed them out, the Health Equity Index. As some of you may know, as part of Medicare Advantage, there's a Quality Stars metrics that is a really important part of the program that really aims to incentivize the best care by MA and Part D plans. And so we embedded, as Doug said, a part of that system now that rewards for excellent care for health equity. I think that will be a really important part of the puzzle in driving this type of improvement of health equity in Medicare Advantage. I think the other thing, and you highlighted it, and I totally agree, is related to utilization management, prior authorization. We had been challenged to better define what the rules of the road are in Medicare Advantage to make sure that folks, no matter where they're entering Medicare, whether through the traditional program or through Medicare Advantage, which, as Doug said, is now about 50-50, how individuals access their Medicare benefits. We want to make sure that you have access to the same benefits that you're entitled to. So really allowing that. Also some things that were on Doug's slide related to transparency and data related to utilization management and prior auth. I think that's an area that we feel like access and equity is really important. And so those are areas that I'm excited. I think one other thing I wanted to add was, as Doug walked through this, I think it's important to remind things, and it's always interesting to me in this role that we have very different levers in different parts of Medicare. So when we, Doug and I are often thinking about with our colleagues who are, have 30, 40 years experience in these areas, advocates will come to us and encourage all of you to bring these things that you're observing in the world to us. And I feel like a lot of our job is to then think about what's the policy solution. And it's important to remember that on the traditional fee-for-service Medicare side, we are the payer. We are engaging with the providers. As Doug talked about, we have levers related to how are we paying the nursing home? How are we paying this specialist? It's a different set of levers in Medicare Advantage where we're paying the health plan or the Part D plan, prescription drug plan. And so a lot of those traditional Medicare things flow through over to MA. So it will impact that. But we also have things like our quality metrics, as I mentioned. We have, how we are going to regulate those plans. So I really like that, where we have to get creative and different levers, whether, the solution is in one part of Medicare or the other.
Thank you so much. And so as a resident expert on Medicare Advantage, I've certainly learned a lot from you over time in Medicare Advantage. As you've thought about health equity in Medicare Advantage, how have you seen the conversation change with time?
Yeah, it's definitely evolved. I think, it's just evolved for the sheer fact that Medicare Advantage has grown so much. I, started working on MA in DC over a decade ago now, and I think, MA was like 28% of enrollment, and now it's 50%, and it's expected to kind of tip over 50% and be the majority of individuals are enrolled in MA as opposed to traditional Medicare. So I think that the thinking has evolved as MA has grown. I would say I think the thing that a lot of people are really focused on now in health equity, but also in Medicare Advantage, is data. Do we have the data we need to really best understand these issues and to connect solutions to challenges? And so I think that there has been a huge focus in the past few years on making sure we have the right data. We definitely, again, back to traditional Medicare, we have a lot of data because we are the payer. We have all these payment systems. I think there is a robust conversation happening right now in the Medicare Advantage space about, what are the additional pieces of data that policymakers need, that members of Congress need, that we all need to ensure transparency, and that we can best ensure that individuals are accessing the care they need, and that we're addressing health inequities in the space. And I think, one other note I would say that has emerged in kind of the evolving conversation here is supplemental benefits. So I don't know if everyone is familiar. So essentially in Medicare Advantage, there's a kind of complicated payment system, but part of the payment system is what's called rebate dollars. So some of the savings that Medicare Advantage plans can extract from how they bid against certain benchmarks we have. I won't bore everyone with the payment formula, but those rebates can be put towards supplemental benefits. And as a result, Medicare Advantage plans have been able to provide additional benefits that are not part of the core. So MA has to provide core Part A and Part B physician hospital services the same as traditional Medicare. But then with these rebate dollars, they can add additional benefits, dental, vision, a lot of transportation benefits, cost sharing. That has really grown over the past 5 years, I would say. It's now $61 billion a year the federal government is paying in these supplemental benefits. So I think there is really a call to action to ensure that those benefits are being spent in a way by plans that are getting to beneficiaries and improving the health of beneficiaries, addressing social determinants. So we've done multiple actions recently, a request for information, collecting more data related to utilization. We are collecting more related to what's called a medical loss ratio. So how much of that money is connecting with individuals. So I think that data generally and specific related to supplemental benefits is an area in MA that's really a hot topic.
Speaking of hot topics, another one that's usually a hot topic is Medicare Advantage is payments. Is there anything you want to talk about there?
Absolutely. I mean, I think, what we do, for those of you less familiar with Medicare Advantage, is we essentially at CMS need to figure out what we would have spent on an individual if they had enrolled in traditional Medicare, and then take that, what's called a capitated set amount each month, and pay the health plan to then care for the individual, as I said, with all of those core Medicare benefits. So that's not easy. We have to look at historical data. We have to risk adjust to ensure that that base payment we pay on a county level. So we have to look at fee for service spending in those different counties. So it's a very complicated system that we're constantly, tweaking and using the best data we can to make sure it's accurate and look at subpopulations and different cohorts to make sure there's not bias in what we're doing. It's what people are paid. So of course, it's going to be a hot topic. We recently finalized some updates to the payment program to put in newer data. We also, as many of you may know, the US healthcare system has been using ICD-10, the coding system, for a while now, and Medicare Advantage, our risk adjustment system, hadn't transitioned to ICD-10. We were still in ICD-9. So ICD-10 has something like 70,000 codes, and I think ICD-9 had 20,000 or less. So it was really complex to map to those new codes and make sure we're paying and really ensure that when we risk adjust, so basically you have that base payment and then you multiply it by a number. And if that number is 2, that means that we think that individual will cost twice as much the average person in that area would cost. And so what we multiply by, we really want those different pieces of the puzzle to be indicators of the predictive cost of that individual. So, I think that it became a very, robust discussion as we made these updates and changes. And I think that that's a healthy conversation to have. I think that health equity was one of the key topics that was raised when we had that conversation. And I think that what we really felt like is that's an important part of the conversation. The whole premise of our current risk adjustment system is to pay more for individuals who are sicker and have more health needs. Before our current risk adjustment system in Medicare Advantage, there was a real concern that there was cherry picking. So you weren't paid enough for the full risk profile of the individual. So people plans avoided enrolling those individuals. So we want to make sure that we are paying accurately and paying more for the risk. But I think something you and I have talked about is getting paid more money for more diagnoses doesn't necessarily mean that person is getting the care. So we have to ensure we're paying accurately, but we also need to have the right levers and aligned incentives in place to ensure that additional payment is making its way to the individual. And that's really where our, STARS policies, our utilization managed prior auth policies, a whole host of different policies that we have ensure that, yes, we get that payment right, but then that money actually goes towards the care that the individual needs in Medicare Advantage.
Thank you. That was great. Okay, so we've talked about a number of different policies today. I went through a lot on the slides. What has the response been to a lot of these policies that have really been trying to promote health equity within Medicare Advantage?
I think it's been really a really positive response. I know my background, I had worked with health plans, and I know that these are conversations that are happening within health plans, within providers. I think it's a collective time where everyone recognizes that we have a real sense of urgency here. I think people have been talking, as you all know better than me, about this for a long time and not seen really tangible changes. So I think that there is a real embrace of these topics. And I think that, one thing that indicates that we did a request for information on Medicare Advantage last summer in July, and we got 4,000 responses. And as part of that, we asked a lot of questions related to health equity. And we really saw great responses across the spectrum of stakeholders who engage in Medicare Advantage. And I think what really encouraged me is it's a lot of stakeholders that traditionally haven't been as involved in Medicare Advantage. I think MA is kind of wonky, and the payment formulas and stars, it can really kind of alienate people who feel like they need to know the nitty-gritty of everything or work with health plans. But I think that we see a lot of beneficiary advocacy, civil rights groups, all sorts of disease groups that are engaging in MA in a way and really making the conversation related to health equity much more robust and helping our ability, as you well know, Doug, to really pinpoint the actual things that we were trying to solve for, and then attach those solutions. So it's not just a lot of conversation or collecting data. It's really then leveraging that to make tangible changes.
Thank you so much. And thanks for coming up here to discuss Medicare Advantage. That was
Absolutely.
great. So I think with that, we really want to hear from you and your thoughts and questions. So the rest of this is going to be a discussion section. And I think you have a microphone. Okay. So I think maybe just raise your hand and she'll come around and give you a microphone.
Hi, I'm Naomi. Let's turn on. Okay. Naomi Sankita from Blue Cross Blue Shield Association. Not really a question, but really just actually want to commend you all when you talk about health equity being in the DNA of CMS and the work that you do. I felt like that was really shown in the work that you did with using the inpatient prospective payment rule last year to impact maternal health equity, right? Like, so you used that rule to create the birthing friendly hospital designation, knowing that Medicare doesn't really pay for maternal health. And so I just thought that was a really cool, impressive, impactful action that was taken that was maybe outside of the traditional scope of, obviously outside the traditional scope of Medicare, but really is having an impact. And I think, as the association with our Blue Distinction Center, we're incorporating those measures and continue, just want to pass along the appreciation of that kind of dynamic of just kind of thinking outside of the box and how do you advance maternal health and advance health equity in ways and leveraging different programs.
Thank you so much for that. I mean, just to say briefly that the disparities in maternal outcomes are just so incredibly profound. So anything that we can do to start chipping away at that, we are thinking creatively, and so appreciate that. Thanks.
Hi, can you hear me?
Yep, I can hear you.
Mazen Yakub. I work for a SaaS software company. You mentioned the emphasis on data to help make decisions and identify where problems are occurring, root causes, et cetera. Also know that SDOH data and the like can be difficult to come by and not always gleaned from claims. Just curious to hear a little bit more about your all's perspective on how to pull together better SDOH data and data that'll help you make good equity decisions.
Yeah, absolutely. Maybe I can start.
Yeah,
if you want to add on too. Thank you. You mentioned the diagnosis codes. There are diagnosis codes for social determinants of health. Many of you probably know this. They're called Z codes, and they haven't been used historically that often. To your point, it's been challenging to collect a lot of this data. We think that probably as we have these new required measures as part of the inpatient quality reporting system, so requirements to screen individuals for social determinants of health needs, food, housing, transportation, utilities, the more of these Z codes will be coded, but we're not there yet. And the other piece of it is also, as we made this recent proposal to include homelessness as a factor that would actually increase payments to hospitals, we think that as a result, more hospitals are going to indicate via Z codes when people are homeless. And so I think as we get better information related to the social determinants of health too, we can more easily see if hospitals incur more resources when they take care of patients who have certain health-related social needs or social determinants of health. So, and Molly, if you wanted to talk about it.
Yeah, and same on the MA side. I think, we collect encounter data. We have, as part of plans, bid pricing tool data. So I think we're really looking at our existing data collection tools and to understand, okay, what data, we have a lot of data. Are we analyzing the data as effectively as we can? But also, is there data that we need, that researchers need? So really just, I think, holistically looking at where those data gaps are. And, we want to make it that it's not reinventing the wheel. So where we have data collection from plans already on the Medicare Advantage and Part D side. If we can, add to that or as I said, leverage that. But I think it's really comprehensive right now what we're doing. And I do think historically, MA, I know CMS did not release CMS MA encounter data until fairly recently, and entities are now getting access to that data. So I think it's a really exciting time in Medicare Advantage because more individuals can look across, because I know it's been frustrating for academic researchers for many years to not be able to kind of look holistically at Medicare, that it's kind of chunked up data. So I think we're really trying to think holistically as well. Okay, what can you figure out in fee-for-service that you're not able to figure out in MA, and what can we do to ensure that we're looking across those different parts of the system?
Hi, thank you. We've talked a lot about data. Standardization of data is priority number one. There's a number of places where you're requiring a certain level of demographic data and then other aspects of SUH data and so forth. How are you thinking about enforcing that with providers and ensuring that you're actually getting the data that you're requiring?
Yeah, it's a good question, and it very much depends on the program and what we can and can't do. One of my realizations, I think, joining the federal government is just how important the different statutes are for the different data and like what we can and can't do in different areas. And so where we have been trying to collect additional information, like we have an optional question on Medicare Advantage enrollment. And this is the first year where we're actually collecting that data. So it's going to be an iterative process and seeing how it's actually working. Are people reporting data as expected? Are there challenges with actually implementing some of these data collection systems? Also in the, didn't mention it today, but in the post-acute care space, we have a demographic data collection as well. That's because statute has said that we can explicitly collect data there. So we're constantly thinking about how we can get better data because it informs all of these other actions as well.
Yeah, I was just gonna, same thing on the Medicare Advantage side. I think we have audits, all the things we do. Okay, great. Our boss, Mina Seshmani, always says, great, we can put the policy out there, but if we're not making sure folks do it, then it's kind of a tree falling in the woods. So regarding data, we absolutely have audit enforcement actions. So we do have some tools if folks aren't complying.
My name is Harriet Arano, and I'm at Cedars-Sinai Medical Center in Los Angeles. And I have a long career, 40 years, in doing preventive health care for older adults and adults with disabilities. And I also am a Medicare Advantage member of Kaiser. And my questions and comments have to do with this whole concept of the predictive cost adjustment that you talk about in Medicare Advantage. And my understanding is that so far it's based on past encounters. Basically, the person, the individual member, has to have had encounters with the healthcare system in order to get assessed, to get their risk adjustment. So you're already not moving upstream to take a look at the member populations based on what their health risks in situ, in their homes, in their communities. And so I'd like you to comment on that. And the other question is, how often, having been a Kaiser member now for practically my entire adult life, how often and now in the Medicare Advantage part, how often are they readjusted? Because what I've observed is that people are now aging in their Medicare Advantage, so they may have been cherry-picked in their younger years, but now they're aging and are costing a lot more to the systems.
Yeah, so I can start. I mean, so risk adjustment happens every year. So those individuals, they're not paid the same amount kind of forever. The plan has to submit codes every year to support the diagnoses of the individual. So So it's a mix of demographic data and counter data. So yes, so basically what we're looking at is predictive analytics on, okay, if that individual has this, COPD or different diagnoses. So it is a diagnosis based payment system. And absolutely, I think we're always trying to figure out the best way to pay for individuals. I will say we have tools and predictive accuracy tools, and we'll look at, okay, Miss McGillicuddy, we paid X amount for their care. And then we can look at the previous years to see if it was that an adequate payment amount. So we do have that historical data. And I think if we were paying inadequately, it would show up. I think actually the conversation in MA is we're seeing more and more of these rebate dollars grow. And there is some concern that there is overpayment in certain areas. So it's really a fine balance to get that payment right.
I think we have time for one more question, so I'm going to pull one from the virtual session. So someone asked, we know many BIPOC low-income disabled are dually enrolled. Medicare Part B reimburses 80% for services for dually eligible beneficiaries, but many states don't reimburse for the cost sharing for those individuals. When its remit, has CMS considered how APMs and fee schedule changes could better support primary care for duals?
That's a great question. I can start if you add to. So we're thinking very comprehensively about how we work together across CMS. We have different centers in CMS. We have the Center for Medicare, which Molly and I are a part of. There's also the Center for Medicaid and CHIP Services, CMCS. There's actually also specifically a duals office, that thinks about policies for individuals who are dually eligible for Medicare and Medicaid. And part of what we've been thinking about really overall, but like increasingly together and in an aligned way, is how we think about these policies and their effect on individuals with duals who are dually eligible for Medicare and Medicaid. So some of what we talked about earlier, the health equity adjustment, that actually rewards excellent care delivered to dually eligible populations in the accountable care organization context, which is delivering care to 11 million people with Medicare, and many of whom are dually eligible. And then in the Medicare Advantage context, the Health Equity Index is also looking at dually enrolled individuals and the care that is delivered to them, specifically with those star ratings. And duals is also what we're looking at in the hospital value-based purchasing program changes and the skilled nursing facility value-based purchasing program changes. And we have actually, there's a kind of like an internal think tank within the Department of Health and Human Services, Assistant Secretary for Planning and Evaluation, and they've looked at the data, and dual eligibility is one of the best predictors of whether or not a population is underserved. And so we're just continuously thinking about the dually eligible populations and what we can do to better serve them going forward.
Yeah, absolutely. And I think, as some of you may know, in Medicare Advantage, individuals who are dually eligible can either enroll in kind of a regular MA plan, but there's also plans called special needs plans that can be specifically designed around duals needs. So we're always thinking, both for individuals who access MA kind of in these general plans, or how can we best make sure that there's care coordination and other special requirements for these special needs plans tailored to duals. So absolutely trying to kind of approach this issue at all angles. But I believe duals is roughly 20% of the MA program now, and the number of duals just generally in the United States is growing. So it's a crucial part of our work generally, but specifically related to health equity.
Just want to thank you all so much for coming here today, and really appreciate the questions too.
Thank you.